This is Insight and Beyond, brought to you by Moorfields Eye Hospital Dubai, a podcast where knowledge meets curiosity. World-leading experts in eye care will dive deep into the world of vision, health, and insights in innovation. Each episode is a step into the future of healthcare and more. Tune in, get inspired, and see the world differently.
Hello everyone, welcome to another episode of Insight and Beyond. My name is Dr. Imran Jawaid. I'm a consultant paediatric ophthalmologist here at Moorfields Eye Hospital Dubai.
My name is Fahd. Quhill. I'm also a consultant ophthalmologist here at Moorfields Eye Hospital Dubai, and my specialist interest is in medical retina and ocular inflammatory disease.
Fantastic. So how are you, Dr. Fahd? You well?
Very well, thank you. And
good.
how are you, Imran?
I'm good, yeah, I'm good. So it's really a pleasure to be talking with you this morning, and I've really been fascinated. So, as you know, I like retinal diseases in children, and it's been a long time since I did retinal disease in adults. And I keep reading about advances in terms of new medications that are available, the longevity. So perhaps like with respect to maybe macular degeneration or retinal vascular disease, do you mind just giving us like a brief update for someone who's out of touch a bit like me?
No, honestly, thank you for that really great question. I mean, I always kind of pinch myself how lucky I am kind of to have picked retina as a speciality, because kind of every year there's always a new development. So as you probably know, back in 2010, 2011, we started with ranibizumab, and then we soon had aflibercept. And there we were given injections every 4 to 8 weeks to manage either wet AMD or retinal vein occlusion or diabetic macular edema. And obviously we've used it in many other conditions as well. And then in the last 3 years, we've moved on to more longer-acting anti-VEGF agents. So what the pharmaceutical companies were able to do was to pack more molecules in the same volume. So it's still the same procedure, still as safe, but now the drug lasts longer. And now I'm able pretty much get a good proportion of my patients to injection to every 3 months.
That's amazing.
So now there are patients like every maybe 3 or 4 injections a year to maintain their disease. But I think in the next couple of years, we will probably move on to devices, something called the port delivery system, where you refill this port with ranibizumab, and you can reduce it to once a year.
Amazing.
Or there are these implants with these something called tyrosine kinase inhibitors, which basically block VEGF from a very high level, because all these molecules are anti-VEGF, but block VEGF from a very high level, and you can implant that, and that can last in the eye for 6 months to a year, again reducing the number of treatments. And if you let me one more thing, gene therapy. Hopefully soon we'll perfect gene therapy, probably through intravitreal delivery, and again we will inject viruses into the eye that are safe, but that are manufacturing the anti-VEGF drug inside the eye, again, reducing the need for frequent injections. So I really feel that we're getting to a point where we're going to manage these effectively with reduced burden of treatment, and hopefully they can get the safety right that we can introduce it to our patients.
Yeah, that's amazing. I think it's a massive advance from back when patients were getting almost monthly injections, which is a big burden for the patients and also for healthcare delivery systems, and which creates big backlogs and inevitably then reduces accessibility of care. So definitely a massive step in the right direction. So that's really exciting.
And the patients get tired, It's the human condition, When we didn't have treatments, obviously that was stressful for the patients because, doctor, I'm losing vision and we can't help them. But now we can help them. Quite rightly, they want treatments that are less intensive, less frequent, because although the injections are very safe and not particularly uncomfortable, if you're having to do that every month, I think it can take a toll. So it's just the smiles in my patients and the kind of relief that we can do the same, but with less treatment.
Yeah, perfect. And all that in 10 years, which is amazing advance in medical technology. Yeah, absolutely. That's really, really great. So, and
it's a running joke I always have with my wife, because she always feels, do you really have to go to all these conferences to keep up to date? Do you really have to travel abroad? And honestly, I'm always pinching myself how much things have changed in a very short period of time. And if my wife is listening, yes, I do have to go to this conference.
I'm sure she is. Oh, amazing. So, I mean, we were quite lucky in pediatric retina, especially in the sense that, so primarily in preterm babies who their retina is not fully vascularized, then they're at risk of a condition called retinopathy of prematurity. And previously, if babies or infants in this preterm babies, if they develop this condition, the treatment for that was laser.
Yeah.
And we would laser all of the non-vascularized retina, and in a sense, destroy that part of the retina really, and leave them with an island of vision and hopefully some vision, to prevent blindness. And really, the advance of anti-VEGF has really allowed us to revolutionize our management approach for these children as well. So we now use lower doses, lower volumes of anti-VEGF. So we have ranibizumab that's now licensed on the back of adults, and then the Rainbow study, and then the Firefly study looking at aflibercept on the back of the positive results from adults, both of which are licensed to inject in children. So this has really helped us as well. But unlike adults, I guess that the one thing that we find as pediatric doctors is that we're trying to balance suppressing the disease but allowing normal vascularization, whereas I guess in adults it's just about suppressing the anti-VEGF for as long as possible because you don't want that choroidal neovascularization, and we're trying to allow for normal retinal vascularization but suppress the abnormal vascularization. So I think trickle-down approach, does make a big difference to our lives as pediatric ophthalmologists as well, where we've been able to use these injections to allow the retina to vascularize a bit more, and we do less laser as a consequence of that, which is better for patients, a lower incidence of myopia and other complications that can arise from this condition. So that's been super helpful.
Yeah, you're right, because obviously if they get uncontrolled ROP, the eye becomes a lot longer and they get a lot more short-sighted because of that.
So generally if you laser a baby, they tend to get posterior segment elongation, so the back of the eye grows quite quickly, and relative to the front of the eye. So in babies with ROP that have relative microphthalmos, the front chamber of the eye is actually quite small compared to the back chamber of the eye. And we've seen from studies that those babies who have laser, they end up being quite short-sighted, and that can be quite debilitating. So I've seen children in my clinic who are 9-10 years old and -18, -19, which has a kind of visual impairment burden associated with that. And actually, when you speak to parents, that's sometimes the hardest thing. It's managing their really expensive glasses or the contact lenses, and then the complications that can arise from daily contact lens wear. So that can be a real burden, and parents often find that a challenge. Versus when now that over the last, I suppose, decade or so, that we've started to use more and more anti-VEGF in very posterior disease, zone 1 posterior, zone 2 disease, that we can allow the retina to vascularize more, so they need less laser. And we've seen from studies that those children that get anti-VEGF, they end up being less short-sighted, which is revolutionary.
Yeah, of course.
And yeah, that's a real positive.
So I'll tell you a few questions I have for you. So obviously, I'm used to giving injections in an adult eye.
Yeah.
And I think, somebody who's a 3 or 4-year-old, I'd probably be comfortable because it's very similar to an adult eye. But obviously, a newborn or a young baby.
Yeah.
Can you tell me kind of what differences you have to make? And then in terms of, again, as an adult specialist in retina, I'm very spoiled. I can do a lot of angiography, so dye tests where I inject a dye in the back of the hand. Yeah. I'm able to really study the eye and kind of find the diagnosis. It'd be interesting for the listeners to work out how it's different in pediatrics.
Yeah, I mean, it's different in the sense that obviously anatomically the eye is different. So versus in an adult, if you're still phakic, the lens is still in the eye, then you'd mark 4 millimeters from the limbus, for example. And in a neonate, you'd mark 1 millimeter from the limbus. So, and that can be a bit of a challenge. But 1 to 1.5 millimeters can be a bit of a challenge. But I think, again, in adults, you can do this under topical anesthesia. You can do this under topical anesthesia in some infants. Sometimes you need a little bit of sedation, but you need support from the neonatal team. And there's varying approaches to how you do it. Obviously, the thing that you never want to ever happen to any of your patients is infection. And so you have to be very vigilant about that. We use all the standard approaches with povidone, drapes, speculums. I mean, personally, I still use a gown and gloves and a mask.
I agree with you.
And
I agree with you.
I know people don't, but I find that I just feel more comfortable doing that and knowing that I've done everything I can to minimize infection, rightly or wrongly. But I don't think it's a major thing to do. So for me, it's not an inconvenience, and I'm not doing 100 in a session. I'm just doing one. So,
absolutely.
So yeah, and having the neonatologist on board is also helpful, so you can help monitor the baby. So obviously, in adults, you can ask them to move their gaze, but you can't in infants. So you sometimes use a little Moody's locking forceps or something or a St. Martin's to hold the eye. And that allows you to make a mark. There's been a publication of technique that allows you to inject intravitreal injections safely in children. So we use a short needle, 4 millimeters, 32 gauge, which means you can advance it to the hub without causing injury to the retina. And I personally benefit from using a 2-person technique. So if I'm holding the eye and advancing the needle and holding it in position, then I can get an assistant just to press the plunger. Now, obviously, we're injecting 0.02 milliliters. In adults, you're injecting 0.05. And very, very small volumes can be really hard to feel. So Novartis have brought out a device to allow you to inject Lucentis using a special technique in a special syringe with a lock, which is quite helpful. If that's not available, then you can use 1 milliliter syringes and titrate it yourself. But I mean, gauging how much drug you're giving can be difficult in that scenario. So yeah, using those devices, I guess that's different too. But aside from that, I mean, yeah, the actual pop the needle in, do the injection, pop some antibiotics in, and you're done. We then have a look in the same way that you would at the back of the eye, check the central retinal artery perfusion, and that's it. But I guess, I don't know, like in adults, but in children, we can see an improvement within 48 hours from injection. So you can see reduced plus disease, you can start to see even some changes to the stage in the periphery. So I think it's just amazing. Like you can visualize the disease, you can see the benefit of the drug. And then I just follow these patients up in a week's time. And
then in angiography, you've got something like a Retcam, haven't you? So you've got a device that allows you to examine them whilst they're under anesthesia.
Yeah, so from adults, we know the importance of angiography. We know the importance of kind of wide field retinal imaging. But previously, there wasn't very much available for children. But now we have the Optos, widescreen imaging device, which some people even use for RP screening. It's fantastic if you can get that set up. But angiography is possible in children. We tend to reserve it in case of ROP for those patients who maybe have peripheral vascular arrest or other things where you might need to delineate where the avascular retina is, or you want to see if there's anything going on at the border. And in conditions like FEVR or incontinentia pigmenti, where predominantly peripheral vascular disease, and there's a risk of tractional retinal detachment. So you would again use angiography in that regard to kind of see, is there any neovascularization, is there any leakage? So again, yeah, we could use that. We can use a Retcam, as you say, which is a fantastic device that allows you to take wide field imaging with a handheld kind of camera when the children are lying down. We can do this in preterm babies generally if they're awake, but in older kids that find it more comfortable, we use it as part of the EUA. And if in clinic, we'd use the Optos, which is less than a second. There's no bright flash. It's really amazing for kids, and we really, really like that. And there are newer devices as well that have been brought out. So other wide field imaging devices that we have access to that are portable and allow us to screen children in clinic, some of which have angiography as well. Yeah,
you're absolutely right. I mean, we've talked about some of the drugs that we use in Retina, but also the investigations or the imaging part of it has really, developed. So, for example, in my speciality, we use something called ocular coherence tomography.
Yeah.
So it's a way of using infrared laser light, but you're able to basically map out an image of the back of the eye. And we use a machine that's, I've got no commercial interest, but it's made by Heidelberg Engineering in Germany. And it's been something I've used all my career. And without it, I don't think I could do my job, because it samples the same area of the retina every time. So if on one occasion I see a change in the thickness of the retina or a new area of retinal fluid or exudation or a change, I can be very confident that it is from the same location, so there is a deterioration, rather than with some other machines where you can't be absolutely confident it's sampling or checking the same area. But then it's got other modalities like autofluorescence, where using a blue light, it's able to pick up a very dim illumination of the retinal pigment epithelium. But because it is able to capture the same image from the same location, and you're taking many images of that same location, you get a very high resolution image that's got a very low signal to noise ratio. So I'm able to really pick out patients with very subtle retinal problems that actually I would miss if I just use standard techniques. And without it, I really, couldn't do my job. And then obviously, the important thing I think that I'd like to kind of get across to the listeners or to the viewers is, I do understand that they get tired from having the regular injections or the regular treatments, but unfortunately, we still haven't got to a point where we can cure, where you give one injection and it's done. What we're able to do is control the disease, minimize its damage on the eye, and maintain vision outcomes. And that to me is a miracle, because before that, patients were going blind. And, the pharmaceutical companies have tried drops, they have tried tablets, they have tried infusions, and nothing has worked except for injecting into the back of the eye. And so, and the analogy I like to use with them is, if imagine you had asthma or blood pressure, you wouldn't expect to be cured from one tablet, one puff. And this is a medical treatment like any other. So it does need regular treatment intervals, but just to kind of reassure them that actually we're getting to a point where you're not needing so much to get the same benefit, but just be patient with us, even though it is frustrating sometimes to have these treatments on a regular basis. But honestly, the drugs are amazing, the outcomes are amazing, and I'm old enough, unfortunately, to remember how these patients were afflicted by blindness and by loss of vision, loss of job, loss of independence, because these drugs weren't available.
No, completely agree. I mean, and just going back to your point about OCT, and angiography, so you now have the ability to do OCT angiography.
Of course, yes.
Which means that you don't necessarily have to have the angiogram by the dye test where you're injecting the fluorescent.
Correct.
You can do it just with OCT, which again is an amazing advance, which makes a non-invasive way of evaluating the retinal blood supply for patients. So yeah, again, medical retina leading the way there. So
I remember when it was launched. So I was at a meeting in America, and it was just for the first time just presented. And then within a year, it was in my clinic. And actually, I remember having to kind of attend lots of courses to really get my head around this kind of new technology. Now I take it for granted, but you're absolutely right. It's remarkable that they were able to work out by just taking two separate OCT scans of the same area. They were able to work out, look at what's different between what's flowing, what's moving between those two scans, and then interpret that as blood flow. And you're right, it's as good as putting dye in, and it's able to delineate the flow of those blood vessels. And has that able me to detect disease, like abnormal blood vessels growing where they shouldn't grow, for example, in the outer retina, or where there's been lack of blood supply. So, for example, a patient I've injected, I'm getting really good control of their macular swelling, the thickness of the retina has come down, yet their vision's not improving. I can do an OCT angiogram and actually show that unfortunately, their retina's health has been affected by their blood supply. And that doesn't mean that the injection has been fruitless, but it allows the patient to come to terms for why the treatment isn't necessarily working.
Yeah. And I guess the other really nice thing about this is it's amazing for us in clinic to be able to show patients exactly, look, this is a photograph of the back of the eye. This is a scan looking through the various layers of retina. This is where the disease is. And then when you treat them, this is the impact and the change structurally that it's had. So they can actually visualize the change in their disease process, or why it may not have worked so well, or why it did work so well, or what we need to do going forward. So that that trust. I think these devices make it really important for me anyway to be able to engage patients and get them to buy into the treatment and why it's important. And so I guess for things like diabetes, where it's not just a local disease, it's a systemic disease, things like this are really helpful.
And you're absolutely right with regards to the buy-in, because if you're seeing your vision improve, but you're seeing your scan improve, you're not just taking my word for it. You're seeing something on the television that is about you, and you can see that difference, and it kind of motivates you to keep going. And I agree with you. In terms of our communication, I'm building that trust. I agree, it's made a difference. Before we wrap up, just to talk about inherited retinal disease. I saw a young lady yesterday. Yes, she's afflicted by this inherited retinal degeneration, but actually she wasn't as bad as I thought. She actually did very well on her visual field, and even though I didn't have a treatment for her, I was able to make her feel better because I was using facts rather than just my clinical acumen or judgment to prognosticate on what her current condition was, what her future condition was. And that really lifted her. And I'm not criticizing other colleagues, but before she'd come to me, they'd really given her a doom and gloom kind of scenario, which actually wasn't warranted. Do you find the same with children, for example?
I would say that things like the wide field retinal imaging, like the OPTAS, the autofluorescence patterns, the OCT, allow us to get a really good detailed analysis of where the underlying problem is. So is it the photoreceptors? Is it an RP? Is it subretinal? Is it something else? Or is it vascular? So I think these things really help us to identify where the disease process is and get a kind of, and there are various phenotypes, like, typically for Stargardt's disease, probably the most common inherited retinal dystrophies, and we've all seen lots of these children. But you can, just using imaging alone, you can give them a diagnosis. But these days, I think the other advantage we have is genetic testing, and that's really revolutionized our practice because you can pinpoint to the gene the reason that these patients have this problem, and there's a growing database of information about how patients with this particular genotype will progress.
Correct.
And you can give them very individualized information. And I'm hoping that, in going forwards, and that some already exist, but certainly going forward, there'll be emerging gene therapies. And if you've been able to identify the actual gene that's causing the problem in your patient in front of you, you can educate them accordingly. When these become available, they may be eligible then for intervention. So I think it's a really exciting time for inherited retinal dystrophies. We're living in a world where there's amazing technology to help make the diagnosis clinically in a non-invasive way. And we also got access to electrophysiology, but also gene testing, which we can do just from our clinic, which I think is just fantastic for our patients.
But you're absolutely right. I think I raised the issue is really just that we're thankfully very good at trying to identify what the underlying cause is, what the underlying gene is, but also from that we're able to work out what their eventual prognosis is. But also there are lots of promising treatments available, particularly for Stargardt's. And I'm really excited in the next couple of years we may have an oral treatment that will slow down the progression of the disease. I think this is our time.
Yeah.
I've really enjoyed actually, and honestly, thank you for sharing some of the differences between our respective specialities. But I agree with you. I think retina is a very exciting speciality, lots of upcoming changes, and I still need to go to these regular conferences.
Yeah, I agree. Thanks very much.
Not at all. Thank you.